Hi guys, this is Charles. I'm one of the surgeons at the Animal Emergency Centre in Melbourne, Australia. We have a really interesting case here, which is we can see this big mass that's on the interior, the medial aspect of the thigh. I don't know if you guys can see the biopsy incision right there. It's a dog that presented with a left hind limb lameness, and it's had multiple CT scans and stuff and biopsies, and was confirmed to be a grade 2 soft tissue sarcoma. The chest was clear, no evidence of any secondary spread to the lungs. And so in order to get a complete margin on this, we're going to have to do a hemipelvectomy. And so that's what we're doing. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. All right, so when you do a hemipelvectomy, we've already done an epidural on the dog, incidentally. When we do a hemipelvectomy, we have to kind of keep rolling the leg back and forth in order to get the approach angle that we need. The other thing is that we're going to have to sacrifice a lot of the skin here because of this biopsy incision. So we couldn't preserve this skin because that biopsy incision is going to be contaminated. I will preserve some of the skin laterally in order to be able to close the defect without any tension. So I make my initial incision on the medial aspect. All right, the other issue is that the mass appears to be encapsulated by the adductor muscle, but it seems to be at least in contact with the penis and with the contralateral adductor muscle. So I am going to take a bit of the contralateral adductor muscle as well. Let's just move this back here a little bit. That's great, thanks. Okay, so I'm going to take a little bit of the contralateral adductor muscle. What's the cautery set on? 20? Can I get cautery set on 30, please? Thank you very much. And we are going to create an abdominal hernia because we're taking the pubis out. And so in some cases, not in every case, we have to put in a polypropylene mesh to reconstruct that kind of pelvic diaphragm. That's getting close to that should be femoral nerve that's in that area, but it appeared to be flexing the stifle rather than extending it. All right, so that's abdominal muscle prepubic tendon right there. And we have Stephanie here from the vet school at Werribee who actually came along with the case. She was the veterinarian that worked it up. All right, so we've got probably penis pretty close, and I've got the separation between the right and left adductor muscles right there. All right, so that's the demarcation between the right and left adductor muscles. So I'm just going to go. Okay, so that's pectineal eminence right there. Do you want to feel that, Steph? So that's pectineus muscle right there and pectineal eminence right there. Now, options for this guy would have been just a routine amputation, although we were concerned about the ability to get a complete margin even with an amputation. Marginal excision in the form of just local excision and then metronomic chemotherapy. This dog's only 2 years old, and so we don't really want to subject this dog to a lifetime of metronomic chemotherapy, which is really what you'd have to do. And then the other would have been radiation therapy. So marginal excision and then radiation therapy. So I'm just dissecting down through the adductor muscles here. that's pectineal eminence. I'm just going just on the contralateral side of the junction between the right and left adductor muscles, and we have to be careful because the penis will be in here somewhere as well. And hemipelvectomy, once you get used to doing it, is actually no harder. In fact, it may be a little easier than a routine amputation. I'm just going to try to get into the abdomen here. So that's the pubis right there. You want to feel that, Steph? And I am going to be concentrating pretty hard, so it's going to be hard for me to answer a lot of questions as I'm going. All right, so now I can feel the pubis, the interior of the pubis right here. And I want to be careful with my Gelpi so that I don't skewer the tumor itself. All right, can you hold on to that, please, Cindy? And these muscle contractions are not the dog feeling it, it's just directly stimulating the muscle. We could use like a harmonic scalpel. We do have one, I didn't. Okay, so that margin at this point feels pretty good. So that's the pubic symphysis right there. Okay, so do you want to stick your finger in there, Steph? And feel the interior of the pubic symphysis? Yeah. Might just move the camera. All right, so that's the pubic symphysis right there. You can feel it coming out caudally back here. Can I have my Homans, and I need a saw, please? So that's penis right there. All right, so I'm just going to get Homan retractors around either side, and that's going to help me protect the urethra internally. You could use ligature to cut the muscle, and we do that sometimes. All right, so we'll just put this back here, and I'm going to palpate the tip of that Homan with my finger. And then I'm actually going to cut down with my finger in there, protecting. All right, so just get my finger out of the way. Try to expose a little bit more bone. So that's obturator foramen right there. Okay, so I feel good about that margin. All right. So we're just waiting for our battery for our bone saw. And I'm feeling the Homan with my tip of my ring finger, and my middle finger. We'll just get some saline going as well, please. Good to go? Is that all the way tight? Yep. All right, so now I'm cutting down onto my finger, protecting the urethra. Okay, dog may be getting a little bit light, just be aware. All right, so let me just get a prayer in here and see if that's separated. It feels like it might still be attached caudally a little bit. No, that's separated. So you can see the gap there in the pubis. All right, so now we can just keep that out there, and then I'll get some DeBakey's and a Metzenbaum, and I'm just going to come around now the pubis. So that's probably our femoral vein right there. Good rule of thumb is don't cut anything you know the name of, or big structures with short names. Another rule of thumb. All right, so that's sartorius right there, I think. My goal with amputations and hemipelvectomies is to lose less than 1 lap sponge full of blood. Okay, so that's the wing of the ilium right there. Do you want to feel that, Steph? Yeah, just to get you oriented. So that's femoral vein right there. That's going to be femoral artery in front of it. All right, so I'm coming around the femoral vein here. It's probably more proximal than I really need to be. Can I get the table up a bit, please?
Yes.
Thank you. That's great, thank you. All right, so now that's femoral vein right there. I'm going to try to get around that with my... Can you reverse? Yeah. I reckon I'm going to leave that for a minute. All right, so we'll pull this out here, and then we'll come around laterally. Get rid of this Gelpy. All right, and then I will zoom back out. And so there's a question that I can see. Can I get a question that I can see about whether the dog would be able to walk? And yeah, there's no problem with walking. There's plenty of support going up through the leg, and then across the sacroiliac joint and into the spine from the other side. So there's no issue with the dog walking. And I have done several dozen of these, and I've never had an issue. All right, so now I've made a curvilinear incision around the front, and I've left more skin laterally than I did medially because I had to go so far medial with my skin incision on the other side. Now I should not have to cut through my biceps muscle. I should be going proximal to my biceps muscle. So I'm just, normally if you did an amputation you'd have to cut through the biceps muscle, but because I'm taking the pelvis out as well, so basically what I have to do is extend or reflect my skin proximally or dorsally. You have to be a little bit careful because you can devitalize the skin if you damage the subdermal plexus. So that's biceps muscle there, and then fascia lata. So I'll just subQ fat there. You have a very, robust blood supply to this skin here. This is kind of close to the flank fold flap. Can I get some Sen retractors, please? Cautery doesn't cut through fat very well because it's not very conductive. So that's sartorius muscle right there. All right, and I am, because the sartorius attaches to the ilial wing, cranial to where I'm cutting through it, I do have to sacrifice the sartorius muscle. So that's down to probably vastus lateralis or rectus femoris. I think it's vastus lateralis. And that's getting close to femoral artery and vein right there. You can see how close they are. All right, so let's lay this down here. So now that we've cut that, we'll grab our Sen retractors here and reflect that skin dorsally. And then with the tension from the Sen retractors, it makes the cautery work better. So basically, we just have to cut through here until we get to the wing of the ilium. The other thing you can do is you can paralyze these dogs with atracurium so they don't twitch as much. So I want to be able to feel my greater trochanter, which is there. Okay, so there's my femoral vein sitting right there. All right, so I'm going to get to the tensor fascia lata. That's greater trochanter there. And that should be middle gluteal there, going up to the wing of the ilium. And that should be the ilial wing right there and the middle gluteal muscle right there. So that's the wing of the ilium right there. Let me just ligashore through this little vessel here. It's a branch of the femoral nerve. You can try to preserve the fat attached to the skin to help preserve the subdermal plexus. There just wasn't any fat in this dog. Reason why I didn't want to ligate the femoral vein and artery when I was around the front was because often there are a bunch of little branches and you'll end up ligating it in the wrong place, and then you cut something thinking that you've already ligated and you'll get a bunch of bleeding. All right, that's probably femoral nerve. We're getting into it. That'll be iliopsoas muscle there. And there is, so that's iliopsoas right there, should be. Thank you. All right, so that's ilial wing there. That's my femoral artery right there. There's another little branch. And we're talking to Steph about the fact that we have to sacrifice that iliopsoas muscle. So let me grab a right angle forcet, please. I'm just going to try to carefully get this right angle around just the iliopsoas muscle and not including the femoral artery. So that's iliopsoas right there. That's femoral artery right there. Can we get some bupivacaine, please? Femoral nerve right there. Femoral nerve travels through the iliopsoas muscle. And so when we're doing a fem-psi block, that's what we're blocking, right? So that's, you see how I always block it in the middle of the iliopsoas, because that's a much easier landmark than trying to find it once it's left the iliopsoas. Okay. So that's our femoral nerve right there. And then we're down to femoral artery, which is right there. Let me just get a right angle around that. And that's, look, you could probably ligashore that, but I just don't feel comfortable with it. So ligashore is good for vessels up to 7 millimeters in diameter. So that's my femoral vein down there. So I think I can ligashore through this little bundle of connective tissue right here. See how there's so much branching of the blood vessels there?
I got the paper we can here.
Thank you. All right, so we're in the abdomen right there, by the way.
Yeah.
All right, so now we've got the femoral nerve here. Go ahead and take the cap off. So I'm just going to go ahead and inject the femoral nerve with bupivacaine. Just to provide a little more pain relief. All right, so now we're down to the iliac wing right here. The sacrum is right up there. All right, I think I feel like I can go ahead and ligate my femoral artery now. Let me just grab a couple of hemostats if we've got them. Thank you. Go ahead and cut in between. Got a little bit of bleeding in here. Not a lot, but I do want to keep to my one lap sponge, so I'll stick that in there. All right, and then I'll just take... Thank you. Can you pick that up for me, please? Come on. Yeah. Thank you. Go ahead and cut that, please. Thank you. So I'm doing a little transfictional ligature on this as well, just to keep the first ligature from slipping off. You can release that, please. Great, thank you. Okay. And then I'll just ligature the distal femoral artery, since that's coming out with the dog, or coming out with the leg. All right, and then get my right angle, please. Thank you. Where are you? Okay, we'll get a couple of hemostats, please. Thank you. Just grab one of those hemostats for me, please. And the vein we don't need to transfix. You can release that, please. Thank you. Yep. Thank you. Next. Just not sure I can get the ligature in there. Let's go ahead and tie that one off. apologize, I'm shaking a little bit. I took some Sudafed this morning. Can you release that, please? For my sinuses. We've got another branch of the femoral artery down there that's small enough to ligashore. But if you had just ligated that one femoral artery that we could see and then left that one, we would have been in a lot of trouble. Okay. So now that's pretty much the major blood supply to the leg. All right, we'll just pull that open a little bit, and I'm just going to dissect through the muscle down to the ilial wing. The reason why I want to expose that is because there's a big branch. Got a little bleeder there. I don't know where that came from. There's a big branch of the femoral artery which comes out medial to the ilial wing, and if you cut through the ilial wing and don't recognize that, you'll get a lot of bleeding, and it's a real problem if you haven't already cut through the pubis, because then you've cut through the ilial wing and you cannot exteriorize it in order to find the blood vessel. So that's colon right there. Stick your finger in there and feel that.
Just there?
Yeah.
Oh,
Yeah. So let's pull that back here. All right, so now I'm down to ilial wing here. I've got my middle gluteal right there. That's great. Thank you very much. I want to make sure that I'm caudal to the sacrum. So let's stick your finger in there and feel the sacrum right there, and that's going to be, go ahead and put your finger in there. Feel cranially, you'll feel the sacral wing.
Okay.
Yeah, so we want to be cranial to this, or caudal to the sacral wing. Dose rate for bupivacaine, I think, is 2 milligrams per kilogram max. Yeah. So this is middle gluteal muscle. I'm just going to cut straight through that, right down onto my ilial wing. Okay. All right, and get another Kelpie, please. Thank you. Get this in a little deeper. Sciatic nerve is going to be in there as well, but we don't really need to worry too much about that because we're going to cut it anyway. I'd rather name it and then cut it, but just pack this in here. Okay, so now I'm going to try to dissect medial to my ilial wing and maybe try to identify that blood vessel before I cut it. So that should be protecting both the artery and the sciatic nerve. Let's get another Homan over the top here. Okay, hold on to that. All right, so we should be good to go here. Okay, so now the leg's released. All right. All right, and then there is our sciatic nerve just holding the leg on. So I'm just going to ligature through this little muscle belly here. All right, and then we'll pack this off here. And so there's sciatic, or should be sciatic nerve sitting, yeah, that's part of it right there. And then there's the vessel sitting right there. So I'll inject the nerve. That is not the whole sciatic nerve, I don't think, because it's not thick enough. And my preference is, somebody asked whether it's your preference to cut it sharp with scissors, and it definitely is. All right, so there's the big vessel sitting right there. You can imagine that being a bit of trouble if you didn't recognize it. Okay, there's the rest of the sciatic nerve right there. Just get another lap sponge, please. I can probably get rid of this guy. There's still a little bit attached right there. Look at the thermal spread that you get with the ligature.
Yeah. It's really obvious.
Yeah. Okay, so that's up to the caudal segment of the ileal wing. Okay. Now the penis is going to be in here somewhere. So I'm going to have to cut through the skin and sub-Q back here. Might get a sen retractor. Do we have a sharp sen? Yeah. right. Can you reach that and zoom out? Just that right there.
Go towards the smaller?
Yeah, that's it. Yeah. That's great, thanks. Yeah. All right, so now I'm just cutting the muscle and skin and sub-Q on the caudal aspect of the leg, mostly the skin, because I shouldn't have to sacrifice most of this muscle. Now let's get rid of this guy here, and we'll reflect that dorsally. So the semi-mem and semi-tendinosus are attached to the ischium, so we shouldn't have to cut them. So that's superficial gluteal right there. So I'm cutting through superficial gluteal here. That's the remainder of the deep. And that is not the dog feeling it, just so you know. No, what's the what's the heart rate? Yeah, go for it. Or do you want to give glycopyrrolate instead? Okay. So we will not send the whole leg off for review. We'll probably just, I'll have a look at it. I'd rather not send the whole thing off, but that's probably sacrotuberous ligament that I'm cauterizing right now. So the leg released a bit when I cut that. Hey? Yeah, that's iliac body right there. So where are we now? I'm just really cognizant of the penis being back here. That's could be like issue cavernosus. Nearly there. You can see as you go how it just gradually starts releasing. Okay, the legs should be off. All right, and so now we're looking at colon right here. We've got a little bit of a bleeder up here. Let me just get a Gelpy in there. Not a big bleeder, but an annoying bleeder. Suction, please. Maybe I'll use Fraser. Thank you. Not sure if that'll work, as it seems to be close to the bone. All right, so I'm really happy with that. Now we just have to decide whether we're going to have to put in a polypropylene mesh or not. Tendency is to say not. I think we've got enough of the ileal wing there and stuff not to need it. If I can avoid a mesh, I would. So I haven't disrupted that much of that fat back there and stuff. I think it'd be pretty unlikely that the stomach would herniate. All right, and I'm not going to put in a suction drain because I don't want to cause any barotrauma with the abdominal contents. I don't like using Jackson Pratts in the abdomen. But I'll see how I'll be able to pull things together. I'm not totally opposed to it. I think we are going to leave, we're going to leave a lot of dead space there. Yeah, I will go ahead and put in a JP. Can I get a Jackson Pratt drain, please? So there's a question about, yes please, about the risk of herniation. It is a risk, although we haven't taken out very much of the pelvic diaphragm here because we left the sacral or the ileal wing intact. And so we've really only got this small area here, and I can pull up this abdominal musculature and suture it up here to smaller.
This is 2 OPS. That is OPS.
Thank you. All right, let's see what I can close here. So I've got that musculature right there. And even if I just do like a web, so that's basically just fix the problem. I
This is just supposed
seems like a good one.
to break. Doesn't give me much detail, so I was like,
Cut please for me, Cindy.
this bowl.
Yep.
Yeah, I think this is the
That's
one.
fine. Yeah.
That's fine.
There's urethra right there.
Oh, that's great.
So suture to the other adductor muscle down here.
The hole's placed quite well.
Yeah, yeah, no, I'm really happy with that. Some of them, I feel like there's a much bigger gap
Yeah.
than this one. You could potentially even drill holes in the ileal wing
Secure.
to suture to, yeah. Trying to pick up the fascia. Don't know how good a job I'm doing. Thank you. All right, so what kind of drain do we have? I'll have to come from outside in because we don't have a trocar. Need a blade. Thank you. And then a hemostat or a right angle. That's great. Thank you. Okay. All right, and I'll cut off the drain so it fits in the incision. 2-0. So I'm just going to do a sub-Q closure here. Just try to find some loose connective tissue in the inside of the skin. And then we'll just do an intradermal on top of this, and then a finger snare. Can you run that for me, please? So I'm trying not to grab onto the subcuticular layer, so I don't want to make an indentation in the skin, so it's smoother. Yeah. I'm running out of sub-Q here.
So there's a question about where is the mass located?
It was in the adductor muscle on the leg that we took off. Hopefully in the leg we took off.
The biopsy kind of.
Yeah, that's right. Hopefully I didn't put the drain right through the mass. We've got another little sub-Q mass, or another little cutaneous mass. No, that's it. Cutaneous mass that we have to take off. Now we're getting a bit more sub-Q back here. You all right?
Sorry.
Oops. Yep. All right, so you happy to do an intradermal there?
Yep.
And a finger snare? And we'll cut this off here. All right. And then you're happy to remove that little mass? Just do a little elliptical incision around it?
Sure.
Okay. All right. Good to go? Thank you very much. They're going to take off the little mass, yep. All right, I'm just going to go back and make sure that there aren't any questions that I haven't answered. Hi, Wisconsin. Hi, Steph. Hi from California. Hi, Philippines. So the anesthetic protocol was, we used... All right, so I don't know if you could hear that, but I used medetomidine, methadone, and alfaxan as our anesthetic protocol, plus the epidural. Hi, Vinay from Mauritius. Hi, Mexico. Hi, Portland, Oregon. And I think that's pretty much it. So I'm going to wrap it up now. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. And we will see you again, hopefully tomorrow. Bye.